And that's why I think RVU compensation is kind of growing in popularity with employers, because physicians still don't have a grasp on exactly what goes on with RVUs.
Welcome to RadCentral, a radiology podcast hosted by Excalibur Healthcare. I'm Laura.
I'm Betsy.
So recently in August, Medscape released a survey which revealed data collected by a bunch of physicians in a whole lot of specialties, which kind of went through the reimbursement systems of RVUs and whether they're fair or not. So we're really asking, do RVUs incentivize physicians to prioritize the quantity of patients seen over the quality of patient care? So we're sitting down with Dr. Sullivan, who is the senior editor at Emergency Physicians Monthly magazine, a practicing emergency medicine physician and an experienced attorney based in Illinois, providing legal services related to the practice of medicine. So welcome, Dr. Sullivan.
Thanks for the great introduction. I appreciate it.
Of course. And thank you so much for taking the time to sit down with us and talk this over. We really appreciate it. So, Dr. Sullivan, let's start off by learning a little bit about you. How did you become involved in both emergency medicine and law? Which came first? What drew you to both of these fields, and how do they complement each other in your practice?
I started out my training as I did a dual residency in emergency medicine and internal medicine. And towards the end of my residency, I kind of did I applied to law school almost on a dare. It was back when HMOs were really big. And my intent was I'm going to put HMOs out of business.
Yeah.
Couldn't stand them and thought that they were horrible for patient care. And by the time I graduated law school, they kind of did it to themselves. They weren't really as prevalent as much. So then I started just doing things to help doctors. I helped review their contracts, and I'd give people advice on medical malpractice cases, and I just kind of kept going from there. So I still practice emergency medicine about 120 hours a month. And then in my spare time, I practice law, review contracts. I represent doctors in front of the medical boards. I still give advice on medical malpractice cases, and I do fun lectures.
No, that's great. It's kind of a philanthropic start, right? You're helping your colleagues with the, relevant information. That's great. Defining RVUs. RVUs are such a complicated system of reimbursement. Can you provide a clear definition of what RVUs are for our audience?
Absolutely. So, and I'll just getting back to the RVU thing. The reason I got into this was because I was trying to help a client who was a surgeon who was not getting compensated properly for our RVUs. So I did a deep dive into what are RVUs, how are they used to pay doctors, how can doctors make sure that they are paid properly for RVUs. So I didn't start out as an RVU specialist, but I kind of tweaked it once I found out that doctors weren't really getting paid appropriately for it. So RVUs is sorry, go ahead.
Oh, I was just, historically, when did RVUs begin to kind of creep into contracts and compensation for physicians? Can you give us a timeline?
Sure. So I can't tell you exactly when CMS came up with the idea of RVUs. I can say in the contracts that I've reviewed, probably in the past 6 to 8 years is when I first started seeing mention of RVUs, and it's kind of snowballed from there. And I think that's for a lot of reasons.
That seems recent. I didn't know it was something that was within the past decade. I would have assumed you'd say something like 20 or 30 years.
No, and I've probably gone through about 800 medical employment contracts in my career, and I've been doing it for about a little more than 20 years. So, I think I've got a decent cross section of what you'd see, but I obviously my experience is maybe different than others, but that just from basic recollection that I'm going to say it's about 6 or 8 years.
Okay.
So RVUs stand for relative value units, and it's a basic component of how CMS decides to pay both physicians and medical providers for treatment. they're initially developed as standardized charges for all the services that patients receive. And the idea behind them was certain procedures require more direct patient care, or they require more physician services or equipment or supplies or technical knowledge. So the CMS said, we're going to try to normalize that and say something that is worth 2 RVUs requires twice as much work or knowledge or supplies as something that involves 1 RVU. So I'll give you an example for interpreting a non-contrast CT of the head, which is a CPT code 70450. You get paid 0.85 RVUs. If you interpret a CT scan of the abdomen and pelvis with contrast, which is CPT code 74177, you get 1.82 RVUs. So a little more than twice as much time and experience goes into reviewing or interpreting a CT scan of the abdomen and pelvis than it does a CT scan of the head. And just for a comparison, if I'm in the emergency department and I interpret a cardiac rhythm strip, I look on a monitor and say, what's the rhythm? That gets 0.15 RVUs. So, and I'm gonna go off on a tangent for a second. I don't know if you guys knew, but I'm a billionaire. I don't like to brag about it much. I keep a lot of my money in my house. So, but I just wanted to show you, this is my billionaire status. I have a $50 billion bill. And I use that as an example to kind of illustrate how RVUs it's a 2-step process. You may say, I'm getting paid 1.82 RVUs for interpreting an abdomen CT and pelvis, or a CT scan of the abdomen and pelvis, but what's the RVU worth? Just the same way as what's $50 billion worth? I bought this off eBay for, I think, $1.50 just to show my kids the effects of inflation. But if you don't know what the RVUs are worth, you can't really determine whether you're getting paid fairly. So once you determine the RVU the value of a service that's provided, then you have to multiply it by some conversion rate, and that conversion rate varies. So there's 2 variables that really go into determining whether you're being paid fairly with RVUs.
Who determines the conversion rate, and why does it vary?
The conversion rates, there's a general conversion rate that's put out by CMS, and I think it's $34 per RVU. It changes a little bit every year, but it's around $33 or $34. Parties can agree in a contract to a different a different conversion factor. I've seen surgeons that get paid $80 per RVU, and I've seen psychiatrists that get paid $12 per RVU. So it varies a lot, and that variable can determine, maybe in a market where there's a high saturation of physicians or providers, they're going to pay less RVUs because they can get away with it. But maybe in a market where they really need medical providers and they want to attract medical providers, then they may pay more RVUs. So it's quite variable.
Sure. Part of this Medscape survey, 7 in 10 doctors think that RVUs are not an accurate measure of cases seen, and they're not an indicator of a timely diagnosis or treatment. So are RVUs accurately reflecting productivity, or are they accurately reflecting how well a doctor can care for their patients?
RVUs, I think that they're a decent measure of productivity, but then you come across Goodhart's law. And Goodhart's law says when you start to measure a target, it ceases to be a good measure anymore. So people quickly learn how to game the system to get to that desired target. RVUs will compensate doctors for some things, but they won't compensate doctors for other things. And my experience so far is that a lot of physicians just haven't caught on to this yet. And that's why I think RVU compensation is kind of growing in popularity with employers, because physicians still don't have a grasp on exactly what goes on with RVUs. Now, some employers may say, they may generate more confusion. They may say, okay, if an employer goes to you and says, I'm going to cut your pay by $30,000, you're going to be upset. And you're going to say, I might not even work here anymore. But if the employer comes up to you and says, we're going to pay you $30 per RVU instead of $35 per RVU, but here's some calculations, and we're based on our calculations, we think you're going to earn more money next year. And physicians agree with that. And if you start looking into the calculations themselves, you see you're getting paid less, but all physicians look at is the end calculations and the numbers. So I think it's the employers are gaming the systems a little bit too.
I read your essay and I read about Goodhart's Law and I didn't know about it. So I dove a little further and found out a little bit more about it. And I thought it was very interesting. Tell me a little bit more about Goodhart's Law and a little bit more about how it leads to the increase of RVU production goals that might be set by CEOs that aren't physicians themselves.
I think I understand what you're getting at. And there are two things. Remember, compensation from RVUs, there's two things you have to consider. One is you have to consider the conversion factor, but the other one is you have to consider the RVUs themselves. And CMS is constantly modifying how many RVUs they pay. So there's two moving targets that you have to keep track of both of those. Will employers take advantage of that? I think they will. I mean, I don't think any employer wants to pay physicians more money. And if there's a way that they can decrease the personnel costs, which is generally the highest cost in any type of a hospital or medical system, they're going to do it. Physicians, when we talk about Goodhart's Law too, it may encourage physicians to either avoid procedures where they don't get paid for it. If there's not a CPT code for it, you're not going to get paid for it, like patient education. So you may avoid that, or you may game the system a little bit. Physicians can do it too. I'll give you an example for emergency medicine. If you drain an abscess, you get paid 1.22 RVUs. If the abscess is considered complex, you get 2.45 RVUs for draining the same abscess. Now, how do you change an abscess from being simple to complex? Either you probe it to break up loculations, or you put a drain in. So if a physician understands that they can make twice as many RVUs just by putting a probe in there and probing for loculations, or by packing it, I think the incentive is to do more, even if maybe the abscess doesn't need it. So, and again, that just goes back to Goodhart's Law. Once you start measuring something, it ceases to become a good measure when you start tying incentives to that.
It says many doctors have felt pressure to up patient count for RVUs. So this is kind of what you're discussing, right? Up billing in order to make more money. You're doing the same procedure. Basically, there's a little bit of an extra step and you're making twice as much money. It says 43% of doctors say they frequently have felt pressure to up patient counts for RVUs. And 30% have said they've occasionally felt pressure to up patient counts. Only 14% have said they've never felt pressure to up patient counts. That's shocking. That makes me think, I'm going to my doctor and they're giving me some kind of procedure. They may do something that's not necessary just to make more money. I mean, I understand that they're still going to help me, of course, but it's also unnecessary, possibly.
And when you get paid by RVUs, if you get paid by a procedure or by the patients you see for the visits you see, and they decrease the amount of money that you're receiving for each visit, the only way to maintain your income is to see more patients. So I don't know if that's beneficial for patients, that instead of seeing a patient every 20 minutes, you make it every 15 minutes or every 10 minutes, just so you can maintain that same RVU stream.
Sure. And then patients feel rushed. Their quality of care declines. It's not a great place to be.
I read something that can relate to radiology, that I read that RVUs can play a part in over testing, that rather than spending time with the patient to discuss more and find out more about what could possibly be bothering them, they are inclined to over order tests because they're quick and easy. But for radiologists, that exacerbates the problem with over ordering of imaging, which is a very big issue these days with the shortage of radiologists. And studies are showing that there's a whole lot of unnecessary image ordering happening.
And that may be the case. I mean, that can be for more than one reason too. That can be because you want to make sure you have every test available so you can make the diagnosis and you don't miss anything. So some of that may be medical legally related. So I don't know that it's exclusively due to RVUs, but I know with radiologists, I mean, if you're doing procedures, that's one thing, but if you're reading films, there's not really that patient counseling component that you would see with a primary care provider or a specialist. And I think that goes back to Goodhart's law. If you're not getting paid, once you start measuring these things, if you're not getting paid to provide counseling or for all the cognitive skills that that are involved in making a differential diagnosis, then I think physicians are going to spend less time doing those things, and they may take the easy route out that just says, okay, I'm going to order another test rather than sit down and think about it and think about a differential diagnosis because I'm not getting paid to do that.
Mm-hmm.
Yeah. Yeah, the testing has an RVU attached to it, but the discussing with the patient does not.
In a lot of cases, and I can't say it in every case, but in a lot of cases, the cognitive value of the physician services is either not paid or it's discounted.
Mm-hmm. Sure.
So they said unnecessary procedures. And then one of the other things in the Medscape survey I saw was that it discourages physicians from entering certain fields because they don't get paid as much, like primary care or mental health, chronic disease management. So
Certainly.
when the value of those services is undervalued by CMS, then the market's going to select against providing those services because doctors want to be paid for what they're doing.
Right, right. So we're sort of discussing, are RVUs impeding the good quality of patient care? Another result from the survey is that RVUs should include qualitative aspects of treatments. 73% of doctors said they should absolutely include qualitative aspects of treatment. That's a lot. So that brings us to discussing sort of like a hybrid model. Is there any way that do you have any suggestions for a hybrid model of RVU compensation in order to fairly compensate doctors for all of this cognitive work and paperwork, all of that time that goes into a patient care, not just the procedure that happens?
Right. So to think about a hybrid model, I think first you've got to think about what are the models out there and what are the pros and cons of each model. So we've got a salary, like a salaried model, an hourly model where doctors get paid either a certain amount per year or a certain amount per hour. And the pros are that it's payment security for physicians. If you see one patient per hour, you see 10 patients per hour, you're getting the same amount of money. Now, what are the cons? The employers are still paying the same amount of money, even if there's a low volume, so you don't have any patients, or if there's a low producing physician. So it may not be fair to the employers if there's a low producing physician, and it may not be fair to that physician's colleagues if they're seeing half as many patients or interpreting half as many studies as someone else who's getting paid the same rate. And that may eventually turn into frustration, which causes the higher producers to leave. And you think about it, if you go to school and everybody in the class gets a B, no matter how much work they do, what incentive is there to do more work?
Right.
So that's kind of the salary model. Then you have a fee for service model, which is kind of what the RVU system is now. And the pros is that it incentivizes more services, but it also drives up costs. And if you're a higher producer, you're going to see more patients, you're going to earn more money. But the cons is obviously it's going to lead to over testing or over treatment, or it encourages provision of services to generate more money. There's also a capitation type of a model where you get a set amount, doctors get a set amount per patient. I know it doesn't really apply as much, although I guess it could apply for radiology, but regardless of the number of services that are provided, you get the same amount of money. And the pros are that it encourages preventative care because you don't want to keep patients, you want to keep patients healthy and not allow them to get sick. The cons is that what's going to happen if you get paid a certain amount of money regardless of how much care you provide, is if there's a patient that's very ill or patients who are likely to have a lot of chronic illnesses, doctors are probably going to avoid them because it's going to cost them more money to treat them. And then you get into this whole value. There's another system of value-based care where providers are awarded for meeting certain outcomes or performance metrics or however you want to look at it. And ideally that's supposed to improve quality. But the big question I have is, how do we define quality? How do you define quality care? How do you define a quality radiology reading? It's tough to do. And so if there's a focus on providing these quality measures, whatever they are, then the providers, that's Goodhart's law. You're going to start focusing on just doing those things because you know that's what you get paid for. And you may neglect other important aspects of patient care. So making a hybrid, I think, is a good idea, where you have to incorporate a lot of those things. Maybe you get a base rate. Say the market value for a doctor in a given area is $300,000 per year. You say, okay, we're going to pay you $250,000 per year, but we're going to give you incentives. So that way there's a base that the doctor knows I'm not going to earn, a third of what everybody else should earn in this area. But I also have the ability, if I work hard, to make more than that $300,000 base. If I see a lot of patients, if I meet the quality metrics. So I think it would have to be a blend of both an hourly, of a RVU or fee for service, and of quality. Adding all three of those, however you're going to make it, just to create both a fair system for compensation, but also a system that rewards high producers and it rewards quality.
Sure. And I mean, that's the way that it seems like it should be going. Just getting doctors involved in the conversation with how they should be compensated, I think, is the first step. I think a lot of doctors feel unappreciated or unfairly compensated. So we went to Reddit and we asked a bunch of radiologists. We said, what are your thoughts on this system of RVUs and how you're compensated for the work that you do? And a lot of radiologists came back and they said, you're going to see a lot of low value cases left on the work list because it's not worth their time to put the time in on it, where they can make just as much money reading a quick one. So it's this cherry picking of cases.
Exactly.
Another radiologist said it's easy to game the system. It makes you less likely to answer the phone or be friendly to colleagues, to do conferences. And they said, I'm against the metric of RVUs. Somebody else said, this is what happens when MBAs and PE groups run medicine. So again, just getting physicians involved in the conversation is, I think, the first step to fix what we're thinking is kind of the problem.
Right. And I could give you a good example from emergency medicine. There are, when we have somebody who, if there's a long list of studies that are waiting to be read, are you, as a radiologist that's getting paid by RVUs, are they going to pick up a quick plain brain where somebody got hit in the head and you're worried about what to look for, and maybe that takes you 5 minutes to read, versus picking up a CT abdomen and pelvis on somebody with metastatic cancer, where you've got to compare old CTs, measure all these different things, and it's going to take you 5 times as much time. Which are you going to be more likely to pick up? Even though a CT scan of the abdomen and pelvis with contrast may pay you more RVUs, if you can bang out 3 head CTs in that same amount of time or less, you're more likely to pick up the easier cases, get paid more, and just run them through the mill. So I completely agree. It's easy to game the system, but that's the way the system's set up, and you can't blame people for gaming the system. So, in terms of getting more doctors involved, that's one of the ways I think we can create a better system, is create some type of an RVU consortium where you get representatives from all the major specialties. They all come to a meeting somewhere and they say, okay, how much are we going to pay RVUs for radiology versus oncology versus emergency medicine versus primary care versus psychiatry? And they all get together and kind of decide between them what's going to be fair and what's going to incentivize care, what's going to disincentivize care. And maybe there's a lot of arguments that break out, but hopefully at the end of that meeting, and maybe you hold that meeting every year so you can address any technological advances or changes in medical practices or things like that. At the end of that meeting, you come to an agreement about how many RVUs or how much a given process in a given specialty is going to pay for RVUs.
That might be the solution. Just getting everybody together to discuss the issues.
I have something to say about the cherry picking. Part of it, I mean, I'm not sticking up for RVUs, but to some degree, the cherry picking based on the idea that they can increase their their own personal productivity score by reading things that that are very high value but don't take a lot of time to read in cases of radiology. To me, it also makes me wonder if that isn't a management issue, because a well-run practice would have radiologists reading everything from oldest to newest, regardless of whether or not the RVUs had different values. So it's a complaint, but you can't really blame the RVUs if the physicians are allowed to cherry pick and make decisions without being overseen by a good manager.
Right.
Sure.
And it can be, and I would say that that's one way of doing it, is saying you get the studies, you have to read the studies in the order that they come. But if a physician feels like they're providing services and they're not getting a fair shake on what studies are next up in the queue, then that may be cause for him to say, I'm done with this. I'm going to go somewhere else where I can cherry pick my patients again. So it's a lot of times market forces play a big role in this.
And then it's definitely a complicated issue and so difficult to find a hybrid model that suits everybody. Let's shift the conversation to AI, which it often seems to do in medicine. Do you have any input on how might increasing the use of technology and AI impact RVUs?
Yes.
That's a tough one. I know.
So I think AI still has a long way to go, but I also think it's improving quickly. And I happen to like it. I've got two AI programs on my phone that I use to help me with differential diagnoses when I'm in the emergency department. And it's getting to the point where I can upload images to AI. I actually wrote an article about this on my my blog about, will AI be able to replace physicians? And I took a couple of derm pictures that I have in a teaching file that I use when I teach students and residents that have never been on the internet before. And I uploaded it to the AI. I said, what's your differential diagnosis? And both times, the two that I picked out got them right away. And they weren't easy. One was disseminated herpes, which you really don't see very often. And another one was erythema nodosum, which again, isn't that common. AI picked them both out right away. So in some senses, I think we got to be careful what we ask for, because as AI matures, I don't think it's going to result in physicians getting paid more. I think it's going to result in physicians getting paid less.
I read something interesting. It was on your website. It was pointing out that as far as RVUs and conversion factors, physicians or providers are getting paid less in 2023 than they got paid in 2022, and even less than in 2021. So is the conversion factor going to keep going down for?
There's really no way to tell. And I know that in 2024, CMS increased the RVU values of some. For example, they increased the RVUs for outpatient medical visits somewhat. So even if the conversion factor is going down, that's why I said it's kind of tough, because there's two different variables you have to look into. Part of it is where the RVU is going, but part of it is where the conversion factors are going. So you have to be able to measure both of those and then estimate based on your prior work what you're going to be able to do with both RVUs and conversion factors and visits and films you read and everything else to determine how much you're going to get paid. So you have to make all these calculations to determine, am I going to be paid more or less or the same as I was last year? And that kind of ties back into the AI as well. Because if you think about it from a radiology standpoint, suppose that AI enables physicians to read more films in less time or to generate reports more quickly. How do you think that's going to affect the payers in the hospitals? Are they going to keep paying you the same amount of money to read the reports or read the films and generate the reports if they know you can do it in half the time? That's
a very interesting point.
So they'll just reduce the compensation for those procedures and they'll pay you less per RVU. And I mean, another thing that we have to think about with AI is it could conceivably be used to track your productivity. So if they have AI that's on your computer and they have a little camera looking at you like my camera's looking at me right now, AI could say, all right, how much time is he looking at the films? How much time is he scrolling his phone? How much time is he surfing the internet? And how productive is the doctor based on all that? They can calculate all these things. So is that something we want to do? Do we want like some little computer snitch watching everything we do every minute of the time we're at work? Because that
Who
could
wrote
be
this
happening
report?
too. Yeah. And on the other hand, maybe AI could also help us to say, this film is a complex film, real time, and say the doctor should get paid more for reading this film because it's complex, whereas opposed to someone who just takes a 5-second look at a plain brain in a kid and said, yep, there's no bleed, next. The AI may be able to differentiate between what's the levels of complexity and interpretations. So, and then.
Thanks for thinking about this for us. I mean, you're bringing up points that seem obvious now, but I hadn't considered them.
Since you're talking to a lawyer, there's a lot of legal issues too. What if you use AI to help you, or if AI comes up with a diagnosis and you adopt that diagnosis and it's wrong, or AI hallucinates because AI hallucinates? And so what happens if AI gives you the wrong diagnosis, or if it leads you down the wrong path for some reason? Who's liable for that? Or I got a better question. What happens if, I mean, right now, Epic is incorporating AI into its electronic medical records, both to generate diagnoses and to refine your notes. So what if the AI refines your report, and when it does so, it changes the meaning, or it changes the report, that what you've actually seen, and it changes it to something that you didn't dictate? Then who's liable? Or what happens if AI says, hey, we're going to use AI to generate billing based on what you read and what you say and what the x-rays look like, but what if it's overemphasizes certain factors, and you submit bills to CMS, and CMS or the payers come back and say, yeah, there's false billing there. You billed too much for this procedure. Then what? So I think there's a lot. AI is a useful tool, but in some cases, I think we may put too much emphasis on it. And I also think that there aren't a lot of people that are really considering the adverse, or the potential adverse consequences of using AI.
Sure. And the bias in the data that's there, right? I know there's a lot of biases in
Right.
age groups, demographics, stuff like that. So yeah, it's just not there yet, possibly. But it's very interesting to talk about.
That's a whole other topic for a whole other podcast.
Yes.
It is.
We'll bring you back in.
I'm happy. I always love talking about stuff like this. It's have fun doing it.
Well, this is a radiology podcast, but this could apply to any physician's contract. So when a radiologist or another physician is being offered a job, perhaps their first job out of training, what advice, as someone who reviews contracts, what advice can you give them for, I guess, being on the alert for clauses about RVUs and whether or not they should suspect that there's something being masked, or something they're not understanding because they haven't done enough research, or they just don't even, they got into medicine to care for patients, and suddenly they're forced to think of things in terms of RVUs, and it's just something that they in over their heads with their very first employment contract. What advice can you give them?
So I've got a contract lecture in itself that lasts an hour and a half. So, so I could sit here and talk for hours about that, literally. But if we're going to focus on RVUs, there's a few things that I'd suggest. I don't think there's ever going to be like a national standard for having RVUs and contracts and stuff like that, just because, like I said, the amount of money that, or the conversion factor, the amount of money that some places pay for RVUs and the value that they put on RVUs and the total compensation is going to change from hospital to hospital, to group. So some of the things that maybe you should consider asking for in the contract is I always try to include auditing rights because I think that's important. That the whole reason I wrote that article on my website was because the surgeon that was involved, they really underpaid her substantially, and she went to try to audit the RVUs, and they wouldn't give them to her. And so we had to make a whole big stink about it. But that's what got the ball rolling with this. So I really think that auditing rights ought to be part of the contract, where the physician is allowed to audit the RVUs they're getting paid for, and maybe even say, if there's more than 15% discrepancy, then there's some penalty. I don't know if the hospitals will agree to that, but that's something I would do just to keep the hospitals on the up and up. Another thing is you really have to keep track of how many RVUs you're making. If you're getting paid by RVUs, you have to track your RVUs. You have to know what patients you're treating, how many patients you're treating. If from a radiology standpoint, understand what tests that you're performing or what you're interpreting, and keep a list of them. And then you'll be able to compare them with the RVUs later once you get paid. Maybe requesting monthly reporting of your RVUs, so instead of demanding it, that should be part of the contract where they do it automatically, either monthly or quarterly if you want to make it quarterly. But I think one of the biggest things is becoming educated about it. You're going to be getting paid based on this $50 billion bill, but you don't even know what the $50 billion bill's worth. And you're going to use that to pay back your student loans and to live on. You really need to be educated about what RVUs are, what are the values for services that you're providing, and you need to be able to figure out how many services am I going to provide during a day, how much am I going to get paid per RVU, and then how much money am I going to get paid per conversion factor for that RVU, so you can determine at the end of the day, am I making a decent salary? So there's a lot that goes into it, but education is probably the biggest thing. The better you understand it, the better you'll be able to deal with it on the back end.
I have a question about, this is about something that I hear often. I'm often told by radiologists looking for work, and I'm just going to make up a number. I'm hoping to make $50 per RVU. From what you've been telling me, it sounds like is there a reason to stating the amount you want to make per RVU if you're saying that the RVUs can differ from practice to practice and environment to environment? Is that a good way for a physician to talk about what they're hoping to earn?
I think that if you just focus on I want this much per RVU, it's difficult to say, because ideally you're going to turn those RVUs into cash at some point. But that's what you hope to do, because you don't pay your mortgage with RVUs. So in saying how many RVUs I want to earn, or how much money I want to earn per RVU, I think you still have to translate it into what's my yearly salary going to be. Because if you say, all right, great, I'm going to earn $50 per RVU, but it's in a low volume hospital where you only read 5 scans for a 12-hour period, you're going to get paid nothing. So you really need to know, you have to have more information about the system and about the patients and everything else before you can just say, I want $50 per RVU. If you estimate, say maybe a radiologist is going to earn generate 7,000 RVUs per year. If you multiply that times 50, that's $350,000, which is on the low side for a radiologist. So you really need to know more about it before you just say, I want $50 per RVU, or I want $40 per RVU. You have to learn more about the system and what you're getting paid before you just come up with a random number like that.
Okay, that makes sense. That makes sense, because I've always questioned whether or not I can take that information and work with it. It seems, and yet they say it so emphatically, so it must be right. They can make $50 per RVU, and I just sometimes don't know how to take that information and turn it into how they can envision their income potential.
And that's what I would relay back to them, is to remember that getting paid by RVUs, there are two variables that constantly go up and down. Even if you fix it to say, I'm getting paid $50 per RVU, so you control one of the variables. One of the other variables can still go up and down in terms of how many patients you see, or what the severity of illness of the patients are, or those types of things. So even if you're making that magic $50, you may not be making as much money if you're not seeing as many patients, or if the patients that you're seeing are less intensive. So you need to know both.
Okay. And this is all, the reason why we find this very interesting for other reasons is we don't use RVUs as a value, as a compensation value unit. We pay the dollar amount per study. So it's pretty easy for a radiologist to do the math and figure out if they read this, they get paid that. And that's why I was surprised that you were saying that RVUs have kind of seeped into our vocabulary in the past 6 to 8 years, you said? It's only been about, okay.
That'd be my guess, yeah.
Because speaking with new radiologists fresh out of training, it's as if they have been taught to speak in RVUs, starting with their residencies and their fellowships. They're already developing this work by the RVU model, and it blows their minds that they can be offered a dollar amount for a study. It doesn't compute. I have a difficult time talking about it with some of them because they just want to turn it into RVUs, or they want to talk about the RVUs that they've already experienced and how they see that going forward into their careers. So they're very RVU. They're very RVU. They speak a lot about RVUs, but I suspect they don't know as much about them as they should.
It's interesting that they're kind of becoming more RVU savvy, but maybe they need to learn more about the nuts and bolts once they get a real job. And I shouldn't say a real job, but once they start their attending jobs, that they're going to want to learn more about the nuts and bolts of how you convert those RVUs into money, or they're going to be left behind, or they're going to get they're not going to get the best compensation package that they could earn.
So, Dr. Sullivan, I know that you do contract review. What else can you help physicians out with in your legal practice? Can you give us a quick
plug for your business?
Yeah, give us a plug.
A plug for my business. What do I do? So I represent in Illinois. I represent people in front of the state medical boards. I sometimes I'll represent doctors when they're getting kicked off of staff at a hospital, just to try. Sometimes things don't work out, and I'll try to help them get the best separation agreement that we can under the circumstances. Or I'll try to mitigate just what happens to them, or try to keep from getting reported to the National Practitioner Data Bank type of thing. So mitigating stuff like that. I try to focus on helping docs understand all the different legal aspects of medicine, because that's something I really don't think is taught in medical school or in residency. So a lot of legal stuff. I try to do a lot of lectures on. I do lectures on contracts and documentation and those types of things. So
you obviously enjoy it. You obviously enjoy it because you're smiling the whole time you're telling us about it. And and the other thing too is it could easily take up all of your time, and yet you are still an emergency physician and an active one. What? Just a quick question about the physician side of you. Why do you love that? I can tell you love all of the legal speak and the RVU talk, but what do you love about working in the emergency department?
Just helping patients. I mean, my God, I actually have a collection. In fact, where I I just got a card, a thank you card. I've got it somewhere. But I got a thank you note from a patient that just said, your care was exemplary and thank you for all you do. I mean, that's like that type of stuff. I mean, that's worth at least 50 or 60 RVUs right there.
Yeah.
Just
There you
being,
go.
I mean, helping people, especially in the emergency department. A lot of times they'll come to the emergency department because nobody wants to be there, but they'll come there because they've got a problem that no one else can solve, and it's just come to a head, and they really need the help. And to sit there and be able to talk with them and help them figure out their problem, even if I can't figure it out, but if I can point them in the right direction and help them get better, or help them, whatever their problem is, go away. I mean, that's pretty awesome. I mean, I think that's a gift that, we've been given by God, and to pass that on to somebody else's, I'd never do it. I mean, if I was independently wealthy, if this was 50
You're a
billion
billionaire.
American dollars, I'd still do medicine just because I love it.
That's great. Dr. Sullivan, how can people find you online if they'd like to use your services?
My website is www.sullivanlegal.us, and I've got a lot of articles up there. When I have free time, I try to write articles about things questions people have asked me, and the RVU article is one of the most popular articles on my site, and that came from an issue that one of my clients was having. So it's helped a lot of other people, which I think is great. So if you've got other questions that you want to ask, just shoot me there's a contact form on there. I don't put my email address on there just because the last time I did that, I got spammed relentlessly. So
I
now it's a
understand.
contact form, but I usually write back within 24 hours of when somebody sends me a contact. So be happy to try to help.
Now, the blog is great. We both have enjoyed reading a lot of your articles. So, Dr. Sullivan, thank you so much for taking the time to sit down with us and discuss all of this very complex and complicated RVU stuff. Your experience, your knowledge has been really educational. I've learned a lot speaking to you. Thank you.
I'm glad. Thanks for inviting me. It's been a pleasure.
Yeah.
If you have anything you would like to add or share about our conversation today, or if you would like to be a guest on RadCentral, please get in touch on www.radcentralpodcast.com. Thank you for listening. RadCentral, a radiology podcast, is hosted by Excalibur Healthcare. Be sure to like and subscribe wherever you get your podcasts. From all of us here at Excalibur Healthcare, have a great week.